factors you will find in today's presentation. So I will start by, just telling you what zoonosis means. And this is not something new. This term zoonosis was coined by Rudolf Virchow in 1880, when he realized that there is no dividing line between human and animal diseases, and these diseases are shared in nature by man and animal. Then in 1959, diseases and infection, which are, these diseases are primarily the diseases of animals which get transmitted to humans. So they defined as diseases and infections which are naturally transmitted between vertebrate animals and man. Second. So there are about 1,475 human pathogens, and of these, 60% are those of animal origin. So that is the importance of zoonosis. And 75% of the emerging infections are zoonotic in nature. So if we have 5 new human diseases that are appearing everywhere, they are of animal origin. And in addition to this, these are agents of bioterrorism. That is why they gain so much of importance. Because they are zoonotic, they are difficult to eradicate. They have a permanent reservoir. So, do you know the human-animal ratio? It is 1:1. So, as many number of people are as many number of animals. So, that is another interface that we have decreased. We're coming very close to animals by our own habits, by our own recreational activities. We are going very close to animals which were out of bounds, like wildlife, going to forests, doing trekking. All these factors have decreased the interface between human and animals and have led to zoonotic diseases come in forefront. Now, how does the disease spread? Now, these diseases were there always, and they were reservoir in animals, and they remain there. Some of these diseases affect animals, and some of these diseases do not cause disease in animals. And the spillover occurs when there is proximity of the domestic habitat with the wild habitat. Usually, it could be due to vectors also, or spillover could be due direct contact with animals, and now even direct contact with humans. And then the amplification occurs in the domestic animals, and then starts the human amplification, like we saw in COVID-19 also. That is a recent example. Nipah virus, similar things happen when with bat, which we will come to later. But this is the basic thing that we have to remember, that the decrease in interface between, coming closer to a wildlife caused emergence of zoonotic diseases. And you see, these are the zoonotic diseases. These are the diseases which cause major epidemics and public health emergency of international concern in the current millennium, starting 2000. With Nipah virus, SARS, Nipah virus in West Bengal, SARS, bird flu, Nipah virus again, pandemic flu, that was a pandemic, MERS-CoV, Ebola. Ebola was a big threat and public health emergency of international concern. Zika virus, again, public health emergency of international concern. So now Mpox, very recently, SARS-CoV-2, we all know. I'm not even going to touch that as of now because of paucity of time. So you see, from every 2 to 3 years, we have had a major outbreak or major public health emergency of international concern due to zoonotic diseases. And we have also seen that these, there is breach in species barrier. Diseases which were totally confined to animals have, shifted from one species to the other, and finally to human beings. These are the list of things. Like for Ebola, it was disease of bats. And now then it came to humans. HIV, disease of primates, shifted to humans. These are there are number of examples which are here. H5N1, we are so concerned about it. H5, we are concerned about zoonotic influenza. And we were, sort of getting ourselves prepared for a pandemic due to influenza Rather it happened due to coronavirus. So, and we were totally unaware, unprepared for such a kind of pandemic. It has taught us a lot of lessons that we will talk about it some other time. So they do, breach the barrier. Now coming to zoonotic diseases of public health importance, because we can talk only about few diseases in 40-45 minutes. So I've just, there are endemic diseases, they are re-emerging infections, and they are newer emerging infections. So endemic rabies, so much of rabies, diagnostics, management, classification has changed. And I was discussing with Dr. Sonal, I think we'll have a separate talk if need be in that. Anthrax, bacterial disease known since civilization, we still are struggling with it. Brucellosis is another disease. Toxoplasma, cysticercosis, echinococcus, parasitic disease, all these are endemic in our country. Re-emerging have been JE. JE had a very localized belt. However, it expanded itself, and now entire Ganges belt, South India sees outbreaks, northeastern states sees outbreaks of Japanese encephalitis. It was known to be disease of children. In northeast now it has it causes disease in adults. And you see, we have started JE vaccination, so in children, but it is shifted to adults in northeastern countries. So even the viruses, they know how to adapt and move on, because it is survival for fittest. They try to survive. So if we don't interfere with their life cycle, then they will not bother us. But if we do it, then of course they will have their means to expand. We should definitely understand microbes are much smarter than us. Plague occurs after quiescence, 28 years of silence, and then there will be a huge outbreak of plague. I'll talk about it in detail. Leptospirosis, scrub typhus, melioidosis. Melioidosis, I believe there will be separate talks, so I won't touch. Kesnur forest disease. And emerging, of course, we've seen avian influenza, Nipah, trypanosomiasis. I'm talking about zoonotic trypanosomiasis. Swine flu, CCH, Crimean Congo hemorrhagic fever, Zika virus disease, COVID-19, Mpox are some of the examples of emerging infections. Let me talk about some of the examples, and let me start with plague. And the outbreak which we remember in our lifetime was that of 1994, which occurred after a gap of 28 years. And this happened in Bid, Maharashtra, and Surat, Gujarat. Started with bubonic plague, went on to be a pneumonic plague. And this was a big setback to India in terms of our, international image. We were so unprepared. And some of you may not even remember that time, because probably people were just born, but I'll tell you that it was so chaotic. People running here and there with masks and didn't know what was happening. Diagnosis was so difficult. Dead body management, there were huge piles of dead body management was so difficult. And there was economic loss of 1.7 billion USD. And why this happened? Because we were not prepared. It happened. There was no suspicion when this happened. There was no laboratory facility to rapidly diagnose. There was poor coordination and management. And finally, health sector was strengthened. And we now have a whole plague unit in Karnataka, which does plague surveillance job. They do surveillance in rats. They do surveillance of fleas. And of course, now the labs, NCDC has a very good lab, which has full facility. So 2002, and we do a lot of training programs also. So 2002 in Hatkoti village of Himachal Pradesh, there was this case who developed breathlessness and went to a doctor, and he gave history of skinning a dead animal. And immediately, because he was Himachal is a plague endemic, was thought to be plague endemic. So that CMO was trained, and he immediately suspected it, that because of the history, sent the patient to Medical College Shimla. From there, the patient was referred to PGI. And when they saw this safety pin appearance bacilli. They informed NCDC and the diagnose that time NICD, and we performed the diagnosis within 2 days. We suspected, informed them, and entire containment measures were put into place. And we had 16 cases and 4 deaths, and the outbreak took about 12 days to call it over. In 2000, so preparedness definitely helped. 2004, Uttarakhand, there were rat falls. People saw it, informed. It was a bubonic plague. You can see the buboes here, the lymph node swelling. And this time, immediately as we saw buboes, we took the aspirates and diagnosis was made in a very limited, within 1.5 days. And there were 8 cases, 3 deaths, and media did not even come to know about it. Why I'm elaborating it so much? That preparedness always helps. So one should be prepared to, there should be high degree of suspicion. And for that, you have to provide adequate trainings, and there should be rapid diagnostic methods. So, then you can avert morbidity and mortality. So plague, can be bubonic, pneumonic, or septicemic, and all follow one after the other. So that is kind of life cycle of plague. And so how do we diagnose? So we can do a smear, gram stain, and Wason stain for safety pin appearance, and DFA, the direct fluorescent antibody test using F1 antigen. And you can see beautiful fluorescence that gives a probable diagnosis. You can culture it and then do DFA from there, F1 antigen DFA, and you can confirm the diagnosis. PCR and DNA fingerprinting can be done. And of course, if time has elapsed, one could do a passive hemagglutination test and passive hemagglutination inhibition test. So from the plague, we learned that the disease will emerge anytime. So we should be prepared. One should have early suspicion, early reporting, and prompt response. And one can avert these outbreaks. Second important bacterial disease that I want to talk about is scrub typhus and rickettsial infections. Now, these are emerging and caused by Orencia shushugamashii, the scrub typhus. And it is characterized by the eschar, which is seen only in 30 to 40% of cases. This is characteristic, but not easily visible. And it is mite-transmitted disease. And here again, high degree of clinical, because symptoms are very vague. So high degree of clinical suspicion, rapid diagnosis, and appropriate therapy will avert morbidity and mortality. And this is a Shushugamashii triangle that you would have heard of, which starts from, this is the geographical area, Southeast Asia, Japan, China involved, Australia in between. So this was the disease of World War. And it was, in our country, it was known to be disease of foothills of Himalayas. So it was reported from Shimla and other places, Himachal Pradesh and other places. And when I joined NCDC, we used to, we had these kits, and the kits would go waste because we didn't get any samples from Delhi and other areas, only from foothills of Himalayas. So we would collect pyrexia of unknown origin samples from the hospitals to test. And that time the awareness was not this high that we are doing a surveillance. We were only doing it actually to not go for kits not to be wasted and not getting caught into audit. And we always got negative results. Suddenly in 2007, we had a case which turned out to be positive. And when we contacted, it was a big private hospital. When we contacted them, they told us that the patient is on ventilator, and they looked for eschar and they found one. And they started doxycycline. Patient was out of ventilator very quickly. Very good response to doxy at that time. But could we give the diagnosis? Now, zoonosis again, we cannot give the diagnosis unless the entire epidemiology. Now, Delhi, we knew had no cases of scrub typhus. And then the entire cycle needs to be completed. So we did epidemiological investigation, found out that at that time, yoga was coming up in big way. And people were walking barefoot in the parks. And this was very posh area in Delhi, South Delhi, where the ground was cleaned to make a park. And we found mite islands there where this person was doing yoga on barefoot, walking, without a yoga, without a mat, and walking barefoot, from where he must have got the disease. You see, so that is the importance of doing the epidemiology and vector correlation before you release your zoonotic disease reports. And subsequently, currently, this disease is being reported from about 22 states. Confirmed cases are being reported. So this has really emerged, and we can diagnose it by doing IgM ELISA. They are rapid diagnostic kits which have variable sensitivity and specificity. Indirect fluorescent assay can be done, and this will give diagnosis of other rickettsial infection also, like Indian tick typhus, epidemic and endemic typhus. And please remember that this organism is very, very difficult to culture. So don't in routine write ki it can be cultured. And even the molecular tests have very poor sensitivity. So our mainstay of diagnosis remains serology. Wheel Felix test, many people argue, and books also say that it is heterophile antigen test, non-specific, should not be done. But our experience at NCDC said that we cannot confirm the diagnosis with Wheel Felix, but it does give indication, because other rickettsia we picked up by doing Wheel Felix. When it was not scrub typhus, WXK, then we looked at other and we could do IFA and confirm. That time even ELISA was available for various diseases. So we confirmed some of the Indian tick typhus cases. And this, as I told you, this disease has expanded its horizon, widely distributed, and because of various, now this is a clear-cut example of how urbanization, globalization, urbanization has affected changing climate and environmental conditions. Now it is reported even in deserts. Rajasthan, Madam would remember, Dr. Bharti had a huge outbreak we saw. So it is in rainforests, in deserts, wherever there are river banks or secondary vegetation. So from everywhere it's being reported. Coming to next disease, the SARS virus. And this is my old slide. I didn't want to change it because, this was the disease in 21st century when it was reported. It spread wide and far in 80 countries within 6 months. Now, this becomes redundant because we've seen the COVID pandemic. And this was after a long time that the disease so rapidly spread and evolved, and this was due to air travel. When somebody traveled from one place to the other, kept infecting people, and staying in hotels further spread the infection. In India, we first noticed a suspect case in March of 2003. There were only 3 probable and 10 suspect cases, and we did not have a confirmed case of SARS-CoV-2. We did RT-PCR at NCDC, and the last suspect case was discharged on 6th June. Multiple actions were taken, and here 5 labs, national laboratories were strengthened, for performing the diagnosis. And SARS, I would always remember for introducing personal protective equipment. That was the first time we heard this term and we got familiar to this term, and we made all the specification for personal protective equipment. And please remember, mask, gloves, gown, everything is a personal protective equipment. Clinicians sometimes, in my experience, I feel that when we say PPE, they think it's a kit. But we know that each individual item is personal protective equipment, and we made kits for easy distribution and easy use, right? Coming to avian flu, influenza per se is a separate topic, but I wanted to bring this up here because I'm talking about zoonosis. And this disease, I would remember for intersectoral coordination. We have been talking about One Health approach and intersectoral coordination for zoonotic diseases, AMR specifically, again, very important. And the turning point for, our efforts was avian flu in India into February of 2006, when really intersectoral coordination was set up. Now, mortality occurs in birds. It started like this, and culling of birds was responsible for, we did culling of birds, And culling was done by veterinary people, but every time a health team accompanied. And I'm sure many of your faculty members will tell you stories about going for avian flu. And why did the health experts go for culling? Because we had to monitor the workers who were working in the field. And this was the time when everybody realized that intersectoral coordination is very, very important. So up to March 21, we have had 203 outbreaks of avian flu in birds. And in 22 states, it was both H5N1 and H5N8, right? And this data is from Ministry of Fisheries and Agriculture. And why we have this data? Because we coordinate with them to know where the outbreak is occurring, so that the workers who are culling or veterinary doctors who are there handling these cases should be monitored for symptoms. We know it's an influenza virus and can rapidly adapt to a new host. It can undergo mutation, mixing of an animal or a human can serve as a mixing vessel. So we are monitoring human suspect cases of when these workers develop disease. So again here, use of personal protective gears and rapid response in field was done with intersectoral coordination mechanism. So outbreaks in poultry are being contained, and one human case has been reported. However, the epidemiological link has not been well established of H5N1. Right now, we were dealing with poultry, and suddenly in Jharkhand in 2011, we got cases of birds, crows dying, and they turned out to be H5N1. What I want to say now, how will you cull? So virus always adapts itself. It finds new host, breach in species, and you have to find new strategies, right? And we are now monitoring the strain, and that is being done by Nishad Bhopal. So this is a laboratory, BSL 3+. This was first the BSL 4 laboratory. Now it is BSL 3+ laboratory, which is monitoring these cases. And we are keeping track of the molecular epidemiology so that we know about zoonotic influenza and its transmission to human cases if it occurs at all. So that is why it becomes very, very important. Coming to next very important disease is Crimean Congo hemorrhagic fever. And this happened in 2011 when you see now how, there was a case, a lady died of viral hemorrhagic fever. Okay, that went off. Then after a few days, the doctor who was treating, he was a young PG. He developed symptoms and died. The nurse assisting him also passed away. Then there was a flutter that something is happening in the hospital, and National Institute of samples were sent to National Institute of Virology, Pune, where they were diagnosed to be case of Crimean Congo hemorrhagic fever. So environmental investigation, that is from ticks also, the virus was isolated, and subsequently the NCDC team, NIV team, Gujarat team, worked together to curtail this outbreak. Now, this was the example of nosocomial infections. Same thing will happened in Nipah also. So here, there will be total breakdown of healthcare system if we don't take universal precautions while handling cases. Especially with viral hemorrhagic fevers, they have to be isolated immediately. NIV Pune also tested the livestock animals in Gujarat and now in many states in India, and they have found positivity in animals in many states. That means that the virus activity is going on. Just that the cycle has to be completed, and ticks have also turned out to be positive, which is being done in Nishad Bhopal, the tick samples, and even in NIV Pune. So these are the indications that we have to have One Health approach and intersectoral coordination to know where the hotspots are and preventive action to be taken. So from 2011, when first outbreak occurred, to 2023, there are about 38 cases of CCHF with 57 fatalities, making CFR to 41% in 15 districts of Gujarat. In 2014, the first outbreak outside Gujarat occurred, and that was in Rajasthan. And in 2015 in UP and 2018 in Kerala. Why this is important? That it is expanding its horizons, and we have to be prepared for providing rapid diagnosis. Now, this is another disease which cannot be diagnosed without the lab, So you have to have high degree of suspicion. So viral hemorrhagic fevers are another question for you. And whenever an IPC and rapid diagnosis, two things become very important when we talk about viral hemorrhagic fevers. So patient should be isolated in that case immediately as soon it may be dengue viral hemorrhagic fever. But if you have a hemorrhagic fever, then the patient should be isolated immediately, wear your PPE, and then start seeing the patient, collect the samples, and evaluate viral hemorrhagic fevers. So CCHF belongs to Nairovirus, Bunniaviridae family. And how does it spread? See, it is there in mammals, and the cycle is maintained by ticks. So there's vertical cycle in tick and eggs also, right? And from tick, it can go to livestock, and the disease in humans can be either through tick bite or through livestock or human-to-human transmission. Incubation period is 1 to 3 days maximum. I think it's 14 days. I needed to correct this. And it responds to antiviral drugs, that is ribavirin, which is such a good thing. That means that if you have suspicion, you diagnose it rapidly, and you can give appropriate treatment. You can reduce mortality to a great extent. Samples to be collected are blood and serum, and post-mortem tissue samples can be collected. Now here, I want to explain this to you, that the incubation is 2 to 14 days. And at the onset of symptoms, initial days, you could do virus culture and viral antigen testing. But this is BSL-4 agent, so culture cannot be attempted by everybody. But PCR can be done up to 10 days of illness. PCR can be done up to 10 days of illness, and after 7 days, serological test can also be done. So this indicates fever and the orange shaded area. At this time, myalgia, fever, nausea, vomiting, diarrhea can occur. So supportive treatment becomes very, very important in these cases. And then, so this is the non-hemorrhagic phase. Bleeding starts during the hemorrhagic phase. And at this point of time, IgM antibodies and IgG antibodies also start appearing. And to clinch the diagnosis this time, you need a paired sera 14 days apart to see rise or fall in titer in IgG antibodies. Right? So it is divided into incubation period, pre-hemorrhagic, hemorrhagic, and convalescence phase. Right? So this is how we make a diagnosis. Then molecular epidemiology becomes very important. This is from a paper from UP, Gujarat. So here you see Indian strains are very close to Tajikistan, Uzbekistan, and other places, right? So which means that there was trade of animal going on in these areas, which we could not confirm how these animals were being exchanged. But this molecular tree gives a important indication that it is a closely associated virus. And this was published. You can see it. Another thing that I want to talk about here is Nipah virus infection. And Nipah virus is Nipah virus discovered in 1999, and first outbreak was reported in Malaysia. And the history goes, it is a severe, rapidly progressive encephalitis, has very high mortality, and close contact with infected pigs or bats can cause infection. And this can cause severe respiratory disease in pigs also. And you know what? In 1998-99, Indonesia, they cleared the forest for urbanization. And when they cut down all the trees, the bats from Indonesia, bats can have a very far flight range. They flew from Indonesia and they came to Malaysia. Now, Malaysia is a small country and they have a lot of fruit orchards. And for the paucity of space, fruit orchards below, they have piggeries because they consume pig meat. So the bats came and they took place in these, they made habitat in the fruit orchids. Now, when they ate these fruits and they threw it down, pigs consume these fruits and they develop disease. And they developed severe respiratory infection, cough, and it was called a 1 mile cough because their cough was heard up to 1 mile. And all the pigs were culled at that time. That time, this new virus was discovered and named as Nipah virus. And it caused, a human febrile encephalitis, which had very high mortality. The disease spread to the adjoining country, Singapore, in abattoir workers who were culling the imported pigs. And then India, this is Pteropus gigantus bat. And this is how the bats, reside in a tree. So in a forest, they will reside in 1 or 2 trees only. So they have a habitat and they stick together. And at 6 o'clock, you can see them fluttering and flying for foliage. They fly away and they find their food and they come back and rest on the same tree. So you have to really spot the tree in the forest where you can see these bats residing like this. And at that time, National Institute of Virology, Pune, tested these bats for Ebola, Marburg, and Nipah virus infection, and they found Nipah virus RNA in liver homogenate of Pteropus bat. Serum was positive for IgG antibodies in the bat, and that suggests possible role of Pteropus bat in transmission of the disease. Now, outbreaks in India. First outbreak occurred in 2001. I had just joined NCDC at that time and we got samples. Now, it was such a panic at that time again because this also started like this, that there were patients of altered sense of fever with altered sensorium, and the driver the ambulance driver got affected and some healthcares got affected. Then people started running helter-skelter. And our NCDC team collected the samples. It was brought to the lab. We thought it was plague. We tested those samples on open benches in 2001 for plague, for leptospirosis. Everything turned out to be negative. Then that time we had a exotic disease course. So we had Rift Valley fever, Hanta fever, immunofluorescence slides. We tested all those and everything turned out to be negative. And 2 years later, this was diagnosed. NIV sent the samples to CDC where it was diagnosed as Nipah virus infection. We were plain lucky to have not got infected by this then because we worked with these samples on open benches. April 2007, we had another outbreak in Nadia, West Bengal. Now, again, this time NIV was well prepared. And they had, as soon as the clinical symptoms matched, so there were only 5 cases, and those were in the family. It was a familial outbreak. All 5 died, and diagnosis was made at NIV Pune to be that of Nipah virus. Subsequently, another major outbreak occurred in 2018 in Kerala. And this was very sad, 19 cases and 17 deaths. In June of 2019, again, 1 case that survived. Kerala is now very well prepared to handle this outbreak. Kozhikode, again, 1 case, 1 death. And now in 2023, I was in Kerala where there were 6 cases and 2 deaths, so case fatality rate. So here again, the case was, all the close contacts of the index, the primary case, were affected. And luckily, and this also happened because when we reviewed the video footages, we realized that they did not follow universal precautions. That is why I said that whenever IPC is also our responsibility. So whenever we have a case of acute encephalitis or viral hemorrhagic fever, first thing is do standard precautions and take standard precautions and follow, only then examine the patients. And unless diagnosis is proved otherwise, the patient should be isolated and samples should be collected and processed in lab with utmost precautions. Here again, last time in last episode, healthcare workers were getting affected, they recovered, but it can cause major collapse of health system, as I will talk about Ebola and tell you what happened in Africa. Diagnosis is made by, we can take NP swab, blood and serum. Urine sample is a very good sample because it gets virus gets concentrated in urine, and it isolation as well as RT-PCR results are much, we get good RT-PCR results in that. CSF, of course, and in case of post-mortem sample, one could take the biopsy from brain, kidney, and spleen. And in early cases, we can do early illness, RT-PCR, otherwise IgM or IgG ELISA can be done. The samples have to be tested. Now we have commercially available kits from the chip-based test. So labs can do it, but as of now, National Institute of Virology, Pune is the nodal agency, nodal lab, which is handling it. The transmission occurs from bat, urine, and blood dropping, or date palm consumption that happened in the familial outbreak in Nadia, and it can get transmitted to humans, or it can get transmitted to pigs by contaminated eating contaminated or half-eaten fruit of bat by human or pigs. Outbreaks can go on in pigs, and in human-to-human transmission can also occur. So multiple modes of transmission of Nipah virus can happen. So that was about Nipah virus infection. Coming to another very important infection, Kyasnur forest disease. This was first diagnosed in 1957 in Karnataka, Shivamogga district. And subsequently, you see, it started spreading in Karnataka itself. And then it shifted to, we saw cases in Kerala in 2014, in Goa in 2015, and in Maharashtra after 2016, and Tamil Nadu. And this is again, it is diseases of monkeys, and once the monkeys die, and the ticks will leave them, the ticks will not be on dead monkeys, so they leave, and then they will find a new host. At this time, when people are crossing the forest or entering the forest, then the ticks will find them as humans as host, bite them, and disease can be transmitted, right? The diagnosis is made by, again, RT-PCR and ELISA test. NIV has a lab in Karnataka, in Bangalore, which tests the samples for Kyasnur forest disease. They do RT-PCR as well as serological assays for that. Anywhere else, and this is again viral hemorrhagic fever, which in later stages can cause encephalitis also and multi-organ failure. And it has high mortality, so one should be aware of it, and one should, we've seen it spreading to adjoining. What stops it from spreading in this global world when people are traveling so much? Coming to Ebola virus disease. Now, Ebola virus was another very interesting story. It was first found in 1976 when it occurred in there were two simultaneous outbreaks in Sudan and DR Congo. And up to December of 2013, there were 23 outbreaks, total of 23 documented outbreaks only in Congo region, in these two, Sudan and Congo region, nowhere else. But what happened in 2013 and 14 was unprecedented. So the outbreak started in West Africa involving 3 countries. And then for the first time, this outbreak became in urban colonies. Before this, it was only in rural Africa. And then it spread to so many countries. So there were about 28,000 cases and 11,000 deaths. This was public health emergency of international concern, declared on 8th August and lifted on 29th March 2016. You see, and these were the countries, United States of America, UK, Spain, Senegal, Nigeria, Italy, Mali, Sierra Leone, Liberia, and Guinea. Here, it started in these 3 West African countries and spread to many other countries, right? And this was caused by the filovirus, Ebola virus family. And the strain was Zaira Ebola virus, right? And it spread through contact of body fluids of symptomatic patients or dead bodies. Now, how did it spread? Because people had a ritual of kissing the dead body, so they most likely the spread started from there. And of course, close contact also was responsible for the spread. Kissing of dead body was implicated, and it does not spread through air, water, or food. So it spread through close contact. And the state was such that by, when the outbreak spread, people started disowning, and there were dead bodies found. When there were teams from CDC who went there, CDC was housed in NICD then, and we saw those pictures. The healthcare workers were involved. They had temporary tents as hospitals, and they had really bad situation, and case fatality, case fatality rate was from 24 to 89%. No vaccine or no approved cure. Only supportive treatment. Incubation period for 2 to 12 days. Why was this a concern? Because this was the largest outbreak affecting multiple countries, which had limited health infrastructure and human resource. From remote villages, it had come to urban area. It has high morbidity and mortality, and there was high mobility of population, which crossed borders with infection. And it became an international concern, and exit screening was started during Ebola. Until then, we were doing entry screening. So people who come to our country, we would screen them. But this time, the United Nations and WHO initiated exit screening from African countries. And so this was, again, our plan was made as pre-epidemic, epidemic, and post-epidemic. We remained in the pre-epidemic period. The ministry was all set, and we'd made all the guidelines in pre-epidemic alert phase. So we'd screen the passengers and categorized the passengers, isolated them, quarantined them in case there was any problem. The crew and the aviation staff was trained. The screening was done. Health forms were filled. Now, this sounds so familiar, but this was done in 2014-15. Thermal scanners were installed. Now, it doesn't seem odd because we've seen all that happening in COVID, but we started this in 2014-15. And did we have a case of Ebola in our country? So there was no active case of Ebola, but because surveillance was done at the airport, we had one case, young male, about 24, 25 years of age, 29 years of age, who was a recovered case of Ebola. So exit screening, they used to get a certificate that I have recovered, because he had recovered very, in a very short time. So we collected all the samples from him, and his semen turned out to be positive for Ebola virus. So you see, we tested and we saw, and we didn't know how to act because we were not prepared to see such a thing. So the sample was also, they said that you get it tested elsewhere also. So we sent to NIV Pune. There they tried culturing it also. They have a BSL-4 laboratory. Only BSL-4 laboratory in human side is at National Institute of Virology, Pune, in Pashan campus. So they tried to culture, and RT-PCR was positive for them also, but we could not culture the virus. And we quarantined this patient, and he was very cooperative. We are so thankful to them. This was taken at highest level in the ministry, and we got samples. That time, WHO guidelines were that you have to quarantine the patient for 3 months. But The patient was kept continuing positive till 5 months and was discharged only after 5 months when his semen turned negative. So this was follow-up. Now, Ebola virus outbreaks continue to occur in DR Congo. And the problem is from Zaire strain, now in Uganda, it has shifted to Sudan strain. Now, this is very worrying that virus will again, as I told you, they are smart and they will change species. Marburg outbreak is going on in Ghana and everybody has eye on it. SARS-CoV-2, I'm not touching. Monkeypox was another one. Orthopox virus, which 2 strains, but we had West African clade, which was milder form. A reservoir host is still not known, although rodents are suspected, but we had few cases. Hand, foot, and mouth disease I've put in here because atypical presentation, Lancet published as tomato fever. Now, again, over enthusiastically reporting, we could have, it is a picorna virus, enterovirus, EV71 and Coxsackie. So it was not new, but it created a lot of panic. HFMD is a well-known disease in children. Dengue is expanding, JE is expanding. Zika virus started in 1947 in Yellow Fever Research Institute. It was first identified. Subsequently, this is dengue ki choti bahan, I say younger sister of dengue. Exactly everything like dengue, much milder illness. And it was public health emergency of international concern because it just spread across the world very rapidly and it causes microcephaly in children, right? Rajasthan had a huge outbreak of Zika virus in 2017, which Dr. Bharti investigated. I was there in her lab for some time, but they did a very good investigation. Xenodiagnosis was also done and RT-PCR was positive in these mosquitoes. And with all these, trichinella outbreak occurred when people in Uttarakhand, that is a parasitic, which I didn't add here, when people consumed, a raw meat or half-cooked meat of a wild boar. And patient ended up in Safdarjung with muscle weakness. It was diagnosed on muscle biopsy and by RT-PCR from Indian Veterinary Institute because trichinellosis is more common in animal. So this is how it is that we have to now move with One Health approach, coordinating with various ministries. So there are future threats also, yellow fever, hantavirus, Rift Valley. They are reported from neighboring countries. We have conducive climate and global travel. So zoonosis will continue to be there. It will continue to emerge and re-emerge. What we need to do is that we have to follow One Health concept that recognizes interrelationship between animal health, human health, and environmental health. So all of us have to work together for zoonosis and for AMR and for many other things. So it should be a collaborative, multi-sectoral, transdisciplinary approach at local, regional, national, and global level. Okay. And it is human health, animal health, food, plants, and agriculture, and environment. Coordinating, collaborating, cooperation, communication, and commitment. All together. We have to do it together. So there should be no dividing line between animal and human health. So emerging infections will continue. Their diseases are just a flight away. And this is my favorite quote. And I always say that microbes and vectors, this quote is from Cross in 1998, and this is for rickettsial infections. Microbes and vectors swim in evolutionary stream, and they swim faster than we do. Bacteria reproduce every 30 minutes. For them, a millennium is compressed into a fortnight. They are fleet afloat, and pace of our research must keep up with them, or they will overtake us. Microbes were here on Earth 2 billion years before humans arrived, learning every trick for survival. And it is likely that they will be here 2 billion years after we depart. So let us respect ourselves. Let us respect human beings, animals, and environment. Your well-being is my well-being is the only way to control, prevent, and control zoonosis. Let's strengthen our labs to diagnose various diseases, being in the formats. So I would stop here. Thank you so much for all your patience and time. If there are any questions, I will take it. And I know that this was a very big, huge lecture, but anything that you need, any of the diseases that you need more, you can either write to us, write to IAMM, they will direct it to appropriate people, or you want any particular like rabies or melidiosis or influenza for that matter, that can be taken further. With you can talk to the organizers, Dr. Bharti, Dr. Sonal, and I'm sure they will take it up further. Thank you so much for your patience, and I can take some questions if time permits. Over to you, Dr. Sonal, Dr.
Thank
Bharti.
you, Dr. Mala. You've really taken this exhaustive topic so well, concentrating on the important points of each of the important pathogen. You really beautifully covered everything. And of course, One Health and zoonosis is a never ending thing. And the way you've described how the clinical scenario, the real lifetime scenario, how to keep our eye open, how to have a high index of suspicion, and how to be ready, pandemic ready, and ready with all these emerging pathogens. So that's the beauty of it. And we really have to be on the alert and have the multidisciplinary or the transdisciplinary and intersectoral approach, and be on the lookout of the new symptoms, and also test for the all possible pathogens as and when required when we are faced with this challenge. I in the chat box I can see one question. Yeah, there's a comment from Suruchi that a very informative and interesting presentation. So thank you, Suruchi, for the comments, and I really agree to that. The presentation was really good. And so, Mala, what do you think would be the important message for these young budding microbiologists? What they have to be ready with as a MD students now? What when they pass out? What should they concentrate when they go out in the labs, private labs, medical colleges, newer medical colleges? How do they, make themselves ready for this challenge of these large number of organisms?
Thank you, ma'am, for that very important question. And I'll break it into two parts. One is how to, for MD students, how to tackle questions. So for that, they have to abstract, they can get questions on bacterial zoonosis, viral zoonosis, or parasitic zoonosis, or One Health, or emerging and re-emerging infection. They should focus on these important things and not give general answers. One is that. Second is very important question that we are also preparing, and these MDs are now our backbones of microbiology. They have to be sensitized to these things, get trained, and they have to have a very clinical orientation to things. Because now, once you prove yourself, with these emerging infections, even clinicians look up to us for antimicrobial stewardship, what antibiotics, diagnostic stewardship, as well as IPC. So, three important branches, many others related to this, but at least these three important branches. So, we have to be prepared and never hesitate in reporting. I would say, if you get something out of routine, try and investigate that instead of being scared, or there is help available. There are important institutes who can work, and everywhere now, that One Health centers are there, zoonosis like SMS at your own center, in your own laboratory. So they should be able to identify these and send samples here for testing and confirmation of diagnosis. And always follow universal precaution and standard precautions, telling your colleagues as well as self. So biosafety, biosecurity is another aspect that we have to take care. All our MDs should be strengthened to do that. Over to you, ma'am.
Very true. I think it is the right time to, highlight the importance of infection prevention control and the use of universal precautions. You also showed a picture of the one of the staff who got infected and died during one of these outbreaks. So that is the real life situation, that you do not know what you are going to come along, which pathogen is going to be presented. You may have viral hemorrhagic fever. You may think it is dengue, chikungunya, but actually it may be CCHF or KFD or any thing new. And similarly, for even for simple influenza and other things. So we are constantly evolving. We had last year many crows who died in many parts of the country. So we found the novel influenza was coming across. So we never know when a new pathogen comes across. So you really must follow the universal precaution and the IPC practices. That will really save you and your patients and your colleagues. So one has to be very careful how you're disposing of your waste, and you also should have a epidemiological bent of mind to track down where the first case was and how it all began and how it is spreading. Like you also told about the I think ambulance worker, he got infected, the nurse got infected. So the in when you see these Nipah CCHF cases, this is how it happens in the hospital setting. Once the one case comes along and the other people even who were present in that room get infected because patient was coughing along. And if you see the detailed history, so it is very important that we take proper precautions, and we also guide the clinicians regarding the same. So I think it's a never ending topic. Thank you so much, Mala,
Yes, ma'am. And
for
the last
beautiful.
thing is now microbiology is not confined to the lab. It is
Yes,
equally
yes.
in the lab and outside the lab also. I think our IMD students can take it up. They should
Yes,
not be
that is
scared of
true.
walking in the hospital and guiding people as to what is to be done.
And
So
even for
microbiology
outbreak
now
investigations,
even in the
like
field.
you've been going into the field. I remember, whether it be Nipah or Zika or CCHF, you've been going in the heart of the outbreak and managing things. So a microbiologist is needed in such time, but then he himself has to take proper precautions and also guide the outbreak investigation in a proper manner, so that you can reach the root cause of the what pathogen is occurring. So we really have to be multifaceted. We're not only in the hospital, but in the community, in the outbreak situation also, and be ready to face the situation. And we have our experts like Mala on online available with us, and you can anytime contact her for any guidance. She really has a vast experience, and the stories she tells about, I think you went all the way in Vande Bharat, or where did you go to pick up those COVID people outside the
Please.
in the flight, I remember. And those were like tough times. And I think very fast you created a lab outside, and dealing in such emergency situation, you must really have presence of mind, be confident, and of course keep yourself and the environment safe. So thank you so much, Mala. I think I can really talk to you for hours and hours and take your guidance. It's just amazing listening to you. Thank you so much, Mala dear. Okay, bye. Good night. Bye bye. You can
Thank you,
send
ma'am.
your
Thank you, Bharti.
questions in the chat. Yeah. Thank you, Sonal, for joining
Ma-
back. So, and great topic and a great speaker you have chosen. Thank you so much.
Thank you, ma'am. This one student wants to know what is the composition of a rapid response team, and especially regarding to personnel and diagnostics.
Especially regarding to?
Diagnostics and lab personnel. What is the composition of rapid response team?
Okay. So
That's what one is.
yeah, it's a good question. Rapid response, when we talk about rapid response team, it is usually for field investigation, and that constitutes of a clinician, a microbiologist, epidemiologist, sometime a veterinary expert, and entomologists. And sometimes we take social people also, social scientists and environmental people. So rapid response team is constituted based on what the outbreak is. And they go in field. When you come to the laboratory, it is mainly the lab persons who are working, but at times we have to coordinate with our veterinary laboratories. Now, certain things like glanders disease, no lab is doing it. So what we have done is we have identified two state-of-the-art veterinary laboratories, one in CMVL Meerut and one in Hisar. They have, because glanders is problem of animals, and we have not seen human case of glanders since many years, decades together. So we need not strengthen our lab, we can use their laboratory. So we can identify such laboratories, especially for anthrax, glanders. We can have, for glanders there is no need because we have not had a human case, but in suspect human cases we can send samples there. So that is the way of identifying, and these labs cannot be identified on individual basis, they have to be done through MOU through governments. So we identify these labs and put them on MOU. So similarly for anthrax, for brucellosis, we have such laboratories and we act accordingly. So rapidly for diagnosis, sometimes we send the samples to identified under MOU veterinary labs also. RRT is usually for field. Does that answer that question, ma'am?
Thank you, ma'am. Thank you. I think it answers it well. Thank you so much, ma'am, for taking this. So with that, we'll close this meeting.
Thank you. And if there are any more questions at any time, you can write to malachabra@yahoo.co.in, or you can send the request to Dr. Sonal and she
I
can.
think there's another question, Sonal. One for so many years, Nipah was contained only to few West African countries. What triggered its global spread in 2013? And you mentioned there are newer guidelines for rabies. That's a question by Rohit Sinha.
So should I answer that?
Yeah, that will be nice.
Yes, ma'am.
Yeah. So again, Nipah virus, as I told you, was disease of bats, and bats have been suffering from this disease from, they carry the virus. They don't suffer from disease. They are reservoirs. So, and bats are potential source of many viruses. Bats will shed their virus only when they are stressed. Like I told you, in Malaysia, they traveled for this distance. After traveling, they were so stressed that they shed the virus. Otherwise, bats are everywhere. And Pteropus gigantus bat, which is the potential reservoir of this Nipah virus, it is there in so many places, entire country. But why it is not causing disease everywhere? This is a big mystery, but only when they go under stress, only when sort of take over their habitat, that they are stressed and they start shedding the virus. This is one of the theories that has been put forward. And of course, rabies guidelines are there. There's WHO TRS. Latest TRS is there. So you can look that up, or you can request IAMM to have a talk. So we can talk about intradermal and various schedules, various vaccines that are there, monoclonal antibodies instead of anti-rabies serum that has come up. So diagnostics, there are newer tests. So whole lot of is there. And NCDC will come up with a manual on, we are writing a chapter on rabies there also. Probably you will get some information through that also.
Yeah, I think that answers it. Thank you so much, ma'am. Thanks again. If there are no more questions, so we'll close this. Thank you so much, ma'am, for the time. And
Thank you, Mala. Thank you, Sonal.
Thank you so much.